Hi, everyone. Thanks so much for joining today's Cone Beam CT webinar. We'll be focusing today on comparison with 2D imaging and 3D applications, and we're very excited to get started. I'm Tracy. I'm a marketing manager here at Henry Schein, and I'm going to be helping with running the webinar and with any questions that you may have. So if you have any questions, please feel free to type them into the Q&A box, and we'll be sure to cover them at the end of the webinar. So please make sure that your volume is up and that any large computer applications are closed to ensure that you're able to view the webinar smoothly. With that being said, and without any further ado, I would like to introduce Dr. Heidi Kohltfarber, who is our speaker for today. So a little bit on Dr. Kohltfarber. She's the owner and managing oral and maxillofacial radiologist for Dental Radiology Diagnostics, and also a Dentsply Sirona 3D trainer. In addition, she is an adjunct professor in the Department of Diagnostic Sciences at the University of North Carolina at Chapel Hill. She received her DDS degree in dental surgery from Loma Linda University in 2003, and in 2012, she received her master's degree in oral and maxillofacial radiology from University of North Carolina at Chapel Hill. Her master's research compared 2D versus 3D radiography in the treatment planning of root canal treated teeth with apical radiolucencies, and in 2007, she received her PhD in diagnostic imaging with an emphasis in craniofacial radiology at King's College London. So with that being said, Dr. Kohltfarber is clearly the expert, and I will let her take it away right now. Dr. Kohltfarber?
Thank you. Thank you so much, Tracy. I appreciate it. And thank you to all of you that have tuned in. I'm very excited to be able to share with you a subject that I'm very passionate about and that I just have a ton of fun with, and hopefully you will too. But talking about 3D imaging as well as some of our applications with 3D imaging. So it's many questions that people ask when we talk about cone beam CT. And so we are going to use the Socratic method, asking questions. Hopefully those are the questions that you've had as well. But first of all, what is cone beam CT and how does it work? What factors should you consider when purchasing a cone beam CT? And there's so many cone beam CTs on the market. We see multiple ones each and every day coming into the market. What are the applications of cone beam CT? So what can you use this technology for? And what is the prevalence of incidental findings? Everyone wants to know, well, what's going to be my return on my investment here? What am I going to be able to see? So we'll talk about some of the research behind those incidental findings. What are the legal responsibilities of owning a CBCT system? All right, so hopefully these are some of the questions that you may have today. We're going to start off with the first one. What is it and how does it work? And in doing so, we're going to take a step back in time just a little bit to the very first dental radiograph. So radiographs were, or x-rays I should say, were first discovered, and the first paper written in about November of 1895. And by January of 1896, just maybe 2 months later, we as dentists had already figured out how to use this technology to benefit us. And so we can see that we have the very first dental radiograph right here. Now, this dental radiograph, you can think of it as the first bite wing, actually took about 30 minutes to acquire, which, of course, is quite a lot of time. Down here, this is one of our 1920s x-ray units, and we see a live wire right there. So if that patient were to pick their hand up, it would be 70,000 volts to the patient. So you want to talk about liability in those early days. That was definitely of concern. And of course, we have, digital x-rays, we have microprocessors. We can acquire these images in a fraction of a second today. Our x-ray units are much safer than those early units, but we're still using that same geometry that we came up with in about 1896. And so that might be a little bit of an issue. The next big advent came with panoramic imaging. So this was about 1950s, 1960s. And those early panoramic units, the x-ray unit was stationary and the patient spun around. So you want to talk about motion artifacts and patients getting sick in your chair, definitely was a problem in those days. All right, so what is the problem of imaging 3D objects in 2D? Well, here's a shocking picture. Here we have Prince William, and it looks like he's flipping off the Associated Press. And we're all thinking, man, he was such a nice guy. What happened? I mean, definitely a shocking picture. And yet, if you look at him from the front, he's actually saying, I now have 3 children. So definitely your perspective makes a huge difference when we're looking at pretty much anything from our images to our radiographs. All right, so where do we go from here? Well, we can go into the third as well as the fourth dimension, and the fourth dimension being time. So we'll talk about that real quickly. All right, when we're talking about our cone-beam CTs, we really have 3 main advantages. Diagnosis and treatment planning is huge. It also becomes the foundation for digital dentistry. This becomes the base of everything else and the jumping off point of everything else you want to do. It's excellent for patient education. So I don't know if you remember when the intraoral cameras first came in. I mean, I remember how groundbreaking it was when I could sit and show Mrs. Jones, yes, there really is a fracture on that tooth. I'm not lying about it. We really saw case acceptance go sky high. And it's the exact same thing with this. Patients love to look at their own scans. In fact, you can go ahead and burn a CD, let them take that home, let them look through their head all day long. And of course, you'd have your office logo on it, so it's a great selling feature for you as well. But patients love to look at this stuff. They love to share it with other people. Excellent for patient education. Actually, cone-beam CT has been around for quite a while. So this is the early 1980s. This is the dynamic spatial reconstructor. And this was actually used for pediatric cardiac imaging. And you'll notice how large it is. It takes up an entire room. Of course, now in 2018, 2019, of course, we have much smaller units. They can fit on a panoramic style unit. Where are we going in the future? Well, it'd be super cool if we had handheld units someday, but I don't know if those are going to come out. Right. It's also a combination of 3 different technologies. So the original units used image intensifiers. So all of the original research was done on those old image intensifier units, but they still have some today, and they're still quite phenomenal. Now we're seeing more and more flat panel detectors, but we're basically using something similar to a cardiac imaging fluoroscopy unit. We use the algorithm for medical CT, and this is just a phenomenal algorithm. It's just amazing that somebody came up with this. It actually won the Nobel Prize originally in 1979, but it's still quite phenomenal that someone came up with that. And this all sits on a panoramic platform to fit in your dental office. All right, let's talk a little bit more about how this works. As it's rotating around your patient's head, it is taking multiple projections. We call those multiple basis projection, or basically multiple images. They can kind of stitch it together, kind of like a video like we see here. This is another example of how that algorithm works. Now, this is actually an abdominal view. On the left-hand side, you're going to see the ray as it rotates around the patient. On the right-hand side, you're going to see the image as it's forming on your screen. So what's happening here is that your computer is crunching all those numbers. It's using that algorithm to go through everything and come up with the image you see on your screen. Why is it so important to spend time to understand that we are using algorithms? Well, it lets us know that we can continually get upgrades over time through the software. So all of this technology is software driven. In fact, if you've ever wondered how it works with medicine, where those medical CT units are about $1 million, $1.5 million, you better bet they don't want those to be obsolete tomorrow. And the way they are continuing to upgrade them over time is all through the software. And that's the same thing with a cone-beam CT. So the machine you have in 5 years from now would actually be better than the one you purchased today, all based on the software. So that is very nice to know, especially in our world where everything becomes obsolete so quickly. Now, trivia question. What does the Beatles have to do with CT? Well, they actually funded medical CT. So at EMI, this was Electrical and Musical Industry Records. They had the musical section and the electrical section. And they had a young electrical engineer who was just a genius who came up with the idea of 3D imaging. But he didn't have any funding for his project. The sales from the Beatles records funded medical CT. And of course, we've never really looked back from that. So we really have the Beatles to thank for all of this technology. All right, how is cone-beam CT different from conventional medical CT? Well, on the left-hand side, we see a medical CT. This has a very, very highly collimated fan beam. Because it's such a highly collimated fan beam, there's actually very little scatter. And that's why we have excellent soft tissue detail. So it hits that receptor is actually going to be 95% signal, only 5% scatter. Now this does multiple revolutions. We say it has an unlimited scan volume. It can go from your head to your toes very, very quickly. But this does come at a higher cost as well as a higher dose to the patient. On the right-hand side, we have our cone beam. This really is a large cone beam. It's not the highly collimated fan beam that we see with our medical CT units. And because of that, there's actually lots of scatter. So it hits that receptor as 80% scatter, only 20% signal. It's the reason why we may not have the soft tissue detail that we see with medicine, but we've had excellent hard tissue detail and hard tissue detail only, which is exactly what we want for dentistry. If we had to go back and remember all of the soft tissues, all the muscles of the face and that sort of thing, it would really take us a lot of time to go through these images, and it really wouldn't be beneficial to us. So it's excellent that we're really just seeing that hard tissue. Now, this does one revolution. We say it has a limited scan volume. It is supposed to just be for your head. But we do see dentists sticking their hands or their feet in it or anything they think that they've broken. In fact, sometimes they'll send them into our private practice and say, hey, did I break my foot skiing over the weekend? Well, as a dentist, I'm right there with you. I'll probably stick anything in that machine I think I've broken. As a radiologist, I have to give my legal caveat. Please don't try this at home. It is supposed to just be for your head. Now, this does come at a lower cost as well as a lower dose to the patient. All right, what factors should be considered when purchasing a cone-beam CT? So what kinds of things should we be thinking about? Well, number one, what will you be using it for? What fields of view and resolutions are needed for the task that you will be doing? So for example, if you are an orthodontist, you probably want a larger field of view. If you are an endodontist, you probably want a smaller, higher resolution field of view. Is the software intuitive and easy to use? And this one is very important. We want to make sure that you feel very comfortable with the software, that it's easy for you. And we do help to make sure that this is as easy a process as possible. Many of you have probably already played with the software. If not, see if you can get a software demo. I think this is one of the areas you definitely want to feel comfortable with. Sometimes we have doctors that will come into some of our courses and they'll say, hey, I purchased a machine, maybe 5 years ago, and I never used it because I couldn't figure out the software. Well, you don't want that to be you. Definitely play with the software. Make sure you feel comfortable with it. What type of support is offered by the manufacturer? And this one's actually very, very important. Many times this can get overlooked, but if nobody's there to actually take your phone call, or if nobody's able to come and fix your machine that has gone down, well, that's lost production time. It's lost money for you. You definitely want to make sure that you have very good customer service, very good support from that manufacturer standing behind you, standing behind the machine as well. All right, so these are the variable fields of view that we will talk about. So we have a large field of view, this one right here, the medium field of view. This is a medium small and a small field of view. So let's show you what each of these look like within the software. So this is a large field of view. And what you'll notice with this one is we will see the mandibular condyles. So you can see your condyles right there. You can see your maxilla, your mandible, and you'll also be able to get airway space. You'll also see cervical spine. So some people want to look at cervical vertebral maturation stages and that sort of thing, definitely you would want a larger field of view. This is the Orthophos SL. This is actually a variable field of view unit. So it will do 11 by 10, 8 by 8, and 5 by 5. The one that's being shown here is the 11 by 10. And you'll notice that you can see, of course, your maxilla and your mandible very well, and we can see airway. What we won't see, you probably won't get the whole cervical spine, and we might just catch just a little bit of the condyles, but you probably won't see the entire temporomandibular joint unless you have a very small patient. What I like about this particular unit is I like the fact it has variable fields of view. I always like to be able to choose. Right, this is an 8 by 8. This is a fantastic workforce for implant treatment planning. What's so great about this is that you see your mandible and your maxilla very, very easily, but you will not get the airway space and you really won't get the temporomandibular joints unless you take 2 scans, do one side and then the other. But this is a fantastic unit. We see this used quite a bit for implant treatment planning. And this is the 5 by 5, the high resolution endo mode. Really only catch about, a couple of teeth in it, but it's very, very high resolution. So, if you're looking for maybe a potential root fracture or widening of the periodontal ligament space, that sort of thing, this is excellent for that. All right. We definitely talk about radiation risks because everybody is concerned, especially our patients. They're concerned about cancer and in utero birth defects. So I think we'd be remiss if we did not discuss this quickly. One of the things that we talk about when we're discussing about dose is we want to talk about the effective dose. This takes into account the volume as well as the sensitivity of those tissues to ionizing radiation. So if you're comparing machines or if you're reading a paper, you always want to look for the effective dose. The other thing that you see here is called the 2007 ICRP. These are tissue weights. They've come up with various weighting factors for all of the tissues in the head and neck, and that is based on studies with the atomic bomb survivors, animal studies, various radiation accidents, and they extrapolate down to the low doses that we see with our diagnostic imaging. And so that's where those tissue weights come from. The latest one is the 2007 ICRP tissue weights. They usually come out with new tissue weights about every 15 years or so. So maybe in the next couple of years, we'll see new ones. All right, with that in place, what about cone beam CT? Well, we see it's highly variable. So if we're looking at large field of view cone beam CT scans for all the protocols that are out there, it can vary between 46 to up over 1,000 microsieverts. So you see there's quite a lot of variability with what is on the market right now. However, on average, a large field of view will be about 212 microsieverts. Medium field of view can vary between 9 to 560. On average, about 177 microsieverts. Small field of view can vary between 5 to 652. So you can see that just because it's a small field of view unit doesn't mean it is necessarily less dose than a larger field of view unit. It's quite variable. But on average, a small field of view will be about 84 microsieverts. So I can say on average, the smaller the field of view, the less dose. But again, we know there are always outliers out there. All right, so how does this compare with other things that we might do in dentistry? Well, this is looking at an example with an 8 by 8 field of view. This is the Orthophos SL, and it is approximately equal to 6 to 7 panoramic radiographs, or about a third of a film-based full mouth series. So those old film-based full mouth series were quite a lot of dose. You could take 3 scans for the amount of dose that those old film-based series were. Just slightly more than a digital full mouth series, approximately 15 days of background radiation. What is that? That's the amount of radiation that you get every day just being alive on the earth. So just sitting in your office or at home, wherever you are next to your computer, you're receiving about 8.5 microsieverts just being alive. And so when we compare that with what we're seeing with our cone beam CT units, it's approximately equal to 15 days of background radiation. What is our chance of in utero birth defects? Well, it's absolutely 0. And let's talk about that, because I did not learn that in dental school. When we are talking about radiation effects, or effects of ionizing radiation, we really see that there's 2 different effects. We have a stochastic effect, which is based on statistics, and we have a deterministic effect. So let's talk about stochastic effect first. This one, the risk is proportional to the dose, and it implies that there is no threshold. So the currently held models say that the damage from ionizing radiation could slowly accumulate throughout the lifetime of the patient, and at some point, something may cause a cancer to begin. So again, we see this with our cancer and our genetic effects. Now, the severity of the effect is independent of the dose. So if Mrs. Jones were diagnosed with stage 4 cancer, doesn't necessarily mean she had more dose, just lets us know that at some point a cancer occurred or it was triggered. Then we have our deterministic effect, and here the severity is proportional to the dose. And we have a defined threshold. So we can say at X amount of radiation, I will see this effect, and under that amount of radiation, I will not see that effect. Certainly, we see this with our radiation burns. We actually have radiation cataracts, which do look different than senility cataracts. Our in utero birth defects is in this category. And we have sunburn there, not because we want to equate our x-ray to a day in the sun. Never want to do that. But a sunburn is a deterministic effect. So if you walk outside for 15 minutes, you're probably not going to get a sunburn. You sit outside for 4 hours, you're probably going to get a sunburn. So it's a time-dependent deterministic effect, very similarly to what we see with our ionizing effects. Now, the threshold at which we will see in utero birth defects is actually 100 to 250 millisieverts. Remember, we've been talking about microsieverts. So in dentistry, we are orders of magnitude below where we would see any type of in utero birth defects. And there's also some really cool things. This is with the Orthophos SL. These are some of the ultra low dose protocols. And so with this one, this is a 22-year-old male. They wanted to look at the wisdom teeth in connection with the mandibular canal. You can see our mandibular canal very, very nicely right there. And this is about 19 microsieverts. So just to give you some context of this, a panoramic image is about 14 microsieverts. So this is just a little bit more than a panoramic unit, and you're able to see things in all 3 planes. There's another one, this 46-year-old male. They were looking at it for an implant check, and they wanted to know where the implant was in relationship to the mandibular canal. Again, we can definitely see that. This is only 9 microsieverts, so we are less than a panoramic, and we're approaching that stage of maybe a set of bite wings. So a set of bite wings will be about 5 microsieverts. So maybe double a set of bite wings, and we have all the capabilities of our 3D imaging. It's another one, 11-year-old female, using it for orthodontic purposes, and they wanted to see exactly where the canine was coming in relationship to the other teeth. You can definitely see that. And this was only 8 microsieverts. Again, just a little bit more than a set of bite wings. So it's just really phenomenal that they've come out with these low dose protocols. And this one is pretty spectacular as well. This is a 17-year-old male. Again, they're looking at it for orthodontic purposes. They want to know where the canine is in relationship to the surrounding dentition. And yeah, it might look a little bit noisy, but this is taken at 3 microsieverts. And for the task at hand, we can clearly see where that tooth is in relationship to the surrounding dentition. So that is just amazing. Less than a set of bite wings. All right, what are the applications for cone beam CT? Well, there's many applications. By far, the driving force behind all of this technology coming into dentistry was implant imaging and treatment planning. So those first papers that came out by Mozo in 1998 discussing an Italian unit was pretty phenomenal. And we're seeing all of this technology come into dentistry as a result of needing a low dose three-dimensional imaging for our implant treatment planning. But we can also see developmental abnormalities, third molar and canal relationships, periapical and periodontal findings, temporomandibular joint imaging. It's great for looking at trauma. We don't have all the superimpositions that we had before. Very easy to see those fracture lines. Pathological findings, yes, we do see those. As one of our professors used to tell us, you may not see pathology in your practice, but pathology will see you. So we want to make sure that we're able to identify it, and it's so much easier to identify it in our 3D imaging. Great for airway and sleep apnea applications. Now, we're not diagnosing obstructive sleep apnea off of a cone beam CT. We could tell Mrs. Jones, you have a limited airway space, and it would open us up for further conversations, and of course, she would need to go on for a sleep study. And of course, there's orthodontic applications, and we can also do segmentation. So we can basically color it in, and anything you can segment, you can 3D print. So you're pretty much set up for 3D printing with this as well. All right, one of the questions that we often will get, when do you use 3D? When do you move from 2D to 3D imaging? The answer is when 2D does not give you enough information to properly manage that patient. It's just as simple as that. One of the things that we consistently see over and over and over again is that 2D will consistently underestimate the bone loss and overestimate the bone gain. You'll see that as we go through this lecture as well. So let's first talk about implant site assessment and the major reason for purchasing it, which may be the reason the majority of you are listening to this lecture today. So here's an example of an implant that was placed. I'm looking at the 2D image. It looks pretty good. Looks like maybe it osseointegrated. We know the majority of them actually do. And yet, where is that implant sitting when we look at it in 3D? We can see that there's actually minimal to no buccal bone support, and that apex is really just floating in air. So we really don't have a lot of bone support for that implant, and it can result in decreased longevity. What about this one? Well, based on the 2D, it looks pretty good. Looks like we could go ahead and restore that properly. And yet, when we move into 3D, where is it actually sitting? It's actually lingual to the mandible. In fact, if we look at it, there's very, very minimal bone that's holding that implant in place. You can see the odd angle that it's been positioned at, and really it's not a restorable implant. All right. So based off of the 2D images, and of course these are posterior maxillary angled PAs, and we can already see what the clinician has done. Went ahead and measured the amount of bone, and we know that's not really the amount of bone that's there. Now, I do need to give my caveat. In radiology, we see the good, the bad, and the ugly. We have a very wide no judgment zone because we know that things happen, and most of us have been there. With this particular case, they were placing implants, and they came running down to radiology, and the comment was they lost the implant. Well, we found it. So there you can see it's floating in the sinus. And in fact, if you look close enough, the implant looks just as shocked as we do. But clearly there's the implant with the implant mount still attached. So of course, this is a very bad day for this clinician. It's a wonderful, wonderful clinician. He has placed thousands of implants throughout his lifetime. Very bad day for him, very bad day for the patient. And really, if 3D imaging had been involved, there's a high likelihood that this would not have happened. So this is the recommendation. This is a joint position paper from the American Academy of Oral and Maxillofacial Radiology in conjunction with dental implantology. And it recommends that cross-sectional imaging be used for the assessment of all dental implant sites, and that cone beam CT is the imaging method of choice for gaining this information. So definitely recommend 3D imaging for implant placements. One of the great reasons, of course, is a surgical guide. So if we have our cone beam CT, we can send it out for a surgical guide, or we can 3D print a surgical guide. Makes it very nice and easy for us, especially if we're first starting out with implants. You actually get a nice little recipe to follow. Many times there's actually an accuracy attached with that. And so this is just a great reason for our cone beam CT. Guided surgery takes a lot of that guesswork out, because we know that just because you have a huge area in which to plan your implant, you can't always place it the way that you want to. And so we do see this time and time again. I definitely would recommend a surgical guide. This is an example. This is post-grafting. And so this is the 2D image, and they wanted to see if the bone had integrated. And based off of the 2D, it looks pretty good. Luckily, they went ahead and they took a cone beam CT before trying to place the implant, because what's really going on here? Well, we see that we have a large fibrous defect. We have a mucosal thickening that is iatrogenic in origin. And where did all of our graft material go? Well, the patient swallowed it. So that was a very expensive swallow. Definitely want to make sure that we minimize those types of incidences, or at least catch it at this stage. We can go back and do something about it before the implant is placed. Developmental abnormalities, yes, we definitely see those. This is a young kid. She's about 8 years old. And we can see that, yes, we have a hypoplastic tooth number 9. There's number 10. Sorry, there's number 10 right there. There's 11. She's been having a lot of pain and drainage coming from tooth number 10. So the root canal treatment was done, and she continued to have issues. Finally went ahead and took a cone beam CT, and a secondary root was found. So definitely we can see that's probably not something we'd pick up on those 2D images. This is another interesting case. This came over from an endodontist. Where is the lesion? So did they need to root canal treat tooth number 7? Did they need to retreat number 8? And this is the area that they're looking in. So this area right here. So this is 7. This is 8. 9 was avulsed years ago. This is 10 right here. This is a 60-year-old female. We're looking in the cone beam CT. Oh, we clearly have a cleft palate. So what was showing up in those 2D images? Well, we can see that our large bony defect was right here. It was being projected across. That was what was being caught in those 2D images. The patient does not need to have root canal treatment. And this was an interesting case, because the endodontist actually called us back after we wrote our report and said, well, the patient says she doesn't have it. Doesn't have what? Oh, she doesn't have a cleft palate. Well, and this is the part I love about radiology. Really, it's the facts, ma'am. You do have a large cleft right there. I think that's one of the best parts with radiology is really, it's been black and white. We don't have to argue about it. And I've never seen anybody that actually wanted to have root canal treatment, but clearly she did. All right, what about this? Well, if I'm looking at it based on the 2D image, I'm saying I have well-defined, thickly corticated radiolucency, left anterior mandible, maybe we have a cyst or tumor, perhaps we need to do a biopsy. But we can look at this with our cone beam CT, and what's actually going on is we have an anterior Staphny bone defect. Does not need to be treated. So if we're looking at this, we see, yeah, we have a large lingual tori, but definitely we have something that is peripherally pushing it on the bone, remodeling it, nice, thick, intact cortical borders. Nothing we need to do about this. Third molar and canal positions. Definitely we can see where the roots are in location to the mandibular canal, decide if we would like to do the extraction or if we'd like to send that on. This might be a case you'd like to send on. If we look at this one, we can see how close that is to the inferior cortical border of the mandible. And where's our mandibular canal? It's right there. In fact, this one also had an oral communication and a periapical lesion. The patient is in pain. So this is a very, very difficult case. And this was actually removed in the OR. The patient was well aware that she could end up with neurosensory deficits or a broken jaw. But this had a eventual successful outcome. Endodontic and periodontal applications, definitely a huge, huge area. And we see quite a lot of apical pathology or apical hypodensities with our cone beam CTs. In fact, this is really what brought me into 3D imaging. Nothing more frustrating than already doing the root canal treatment, already restoring the tooth, and yet the patient still has pain. So this patient had come back several times. We've taken the 2D image, and you can see, yes, we do have a large post, but we have this apical radiolucency centered basically at the apex. And yet when we look at it with our cone beam CT, we can see we have a J-shaped radiolucency, extends right to the termination of that post, lets us know that we do have a root fracture. Now, we may not always see the fracture line, particularly with the root canal treated tooth. We do have beam hardening artifacts, but we can see the evidence of a fracture. And so if we don't have any bone loss, I'm going to say we probably don't have a fracture. But if we start to see all of this bone loss here, yes, we have good evidence that we do have a fracture going on. All right. Did you know that new research reinforces the need for early detection of apical periodontitis? We're seeing that there is a connection between apical periodontitis and an increased risk for cardiovascular disease. Shouldn't be a huge surprise. We saw this a while ago with periodontal disease. So anytime we have a chronic inflammatory process going on, we have an increased risk for cardiovascular disease. We also know that the size of the lesion at the time of discovery and the time of treatment, will really determine its success. So the larger that lesion is, the less likelihood that we will be able to successfully treat it. So if there's quite a lot of bone loss, it might be better for that patient to go ahead and do an extraction and place an implant rather than heroics to try and save it. Just knowing that there's a greater risk for failure of that treatment when we have a larger lesion. Here's a couple other examples of using it for endodontic applications. This patient had come in multiple times again. We're not entirely sure which tooth was causing problems. We have lots of superimposition in those posterior maxillary PAs. Yeah, we took the cone beam CT and we can clearly see we have a localized mucosal thickening in the sinus that is of odontogenic origin. Nice periapical lesion going on right here. And we have erosion of that inferior cortical border of the sinus. Why can we see it so much better? Well, some of the original research that was done at the end of the late 1960s by Bender and Seltzer said unless the buccal and lingual cortical borders were breached, we really can't see that lesion in 2D. But here we can clearly see that lesion because we're able to look between the cortical borders. This was another case. This was sent in by a dental office. And really quite a phenomenal case. The patient didn't even know that she had this going on. This was actually the dentist's wife. She happened to just hop into the machine when they were taking the images. They were first setting up the cone beam CT, and she didn't even know that she had this happening. In fact, she had complained of sinus problems for over 20 years. More recently, she was having vision problems on that left-hand side. And here we can clearly see we have a large lesion. When we asked her about it, she said, well, she's had no drainage, no pain, no problems with it. I'm not quite sure how it was not loose. But in any case, we know that inflammation and malignancy can look very, very similar. They're on each other's differentials. So in a case like this, where there's no drainage, no pain, otherwise looks like a healthy tooth, definitely want to biopsy that and see what's going on. And she, in fact, had a large sinus tract that went all the way up to the orbit. So where is that lesion going after the orbit? It's going to extend right through into brain. So this is potentially life-threatening lesion for her, discovered by cone beam CT. So she actually had tracked me down one year at DS World and said, please show this. This technology saved my life. And we hear these stories over and over again that this technology is able to save lives of family members, in-office personnel, and our patients. So very, very powerful technology that we're using. We can definitely see our temporomandibular joints with this. So we can assess osteoarthritic changes. We use something called the research diagnostic criteria for TMD. It takes 11 different criteria, osseous criteria, and it funnels down into 3 different diagnoses. No osteoarthritic changes, indeterminate, or yes, we have osteoarthritic changes. So let's look here. Here we see nice, smooth, intact cortical borders. So this is a normal condyle. This is a bifid condyle, but it's still considered normal. Very first thing we might start to see is flattening, first at that posterior lateral pole, but we still have thin, intact cortical borders. So this is considered to be indeterminate for osteoarthritic changes. Down at the bottom here, we start to see little surface erosions, pitting in those cortical borders, usually at the superior articulating surface. That's usually the first sign of osteoarthritic changes. We can see that we have bony apposition at the anterior aspect. This is our anterior osteophyte, and it has a bird beak type appearance. In this one, we see generalized sclerosis, anterior osteophyte, and something that looks like a little cyst. This is a subchondral pseudocyst. It is not epithelial aligned, and they can spontaneously heal by themselves, but definitely tells us we have osteoarthritic changes. Great for trauma applications. Obviously, we don't have all that superimposition, so we can easily see fracture lines. Great for pathological findings. And again, even if you didn't know what this entity was right here, you could compare it to the other side. You could use symmetry and say, hey, this looks a little bit wider, more expansion when I compare it to that side. We can see there's a different density. And we can go ahead and choose to send that on, even if we don't remember from our dental school days that that is fibrous dysplasia. This was a case in which, based off the 2D imaging, they were going to do a $500 biopsy. I thought, wow, what is that right there? We definitely need a biopsy. Maybe that patient has bone cancer. Yet we get into it, which you can see, it's the same density as cortical bone. It's continuous with cortical bone. And this is what's known as a dense bone island or idiopathic osteosclerosis, and no biopsy is needed. Again, segmenting out the airway space for sleep apnea type applications. We are just letting Mrs. Jones know that she has a limited airway space. One of the things I do like is the adjustable appliances so that we can take the temporomandibular joints into account. I want to make sure that we don't cause any issues back there with osteoarthritic changes as a result of where we have titrated that jaw to. Great for orthodontic applications, so we can recreate our lateral and PA ceph. We can look at the orientation or morphology of the teeth, the relationship to other teeth, path of alignment. So this was a case, this was a facially placed canine, and they thought maybe it would take about 9 months to correct that orthodontically. And based on the panoramic reconstruction, it did look like that would be the case. And yet when we get into it, how much bone is actually holding that tooth in place? Very, very minimal bone. So that would change the treatment planning for that particular case. In segmentations, we can color it in. Anything that we can segment, we can also 3D print. With this one, we could overlay time1, time2 with the condyles, and we can start to see, yeah, we've got some little erosion going on. We can do color mapping and highlight in red where exactly the differences are. We can use this for periodontal applications as well. And so this is a paper that we just published. And we had a defect between our first and second molar. So this is pre-defect in the 2D, post-defect. That's pretty hard to see. But we can go ahead and segment at time 1 and segment again at time 2, overlay it, and then highlights in red any differences in bone over time. So this would be very, very easy to implement in our offices. So really our digital dentistry today is just the tip of the iceberg. A couple other things we quickly want to talk about. This technology is not great for caries. We do have quite a lot of beam hardening artifacts, so it makes it look like we have caries when in fact we do not. So we don't want to use this for caries, but it is great for periodontal applications. endo applications, looking at our unfilled canals, possible root fractures. For many people, this becomes a panoramic replacement. So are we to all-in-one imaging? Well, not quite yet. We really haven't moved beyond the intraoral bite wings to look for caries diagnosis. Again, we want to remember to have that we want to look at team support, special technical support, maintenance and upgrades. Really, the team behind you is very, very important. And we know the ultimate winner really is the patient. I love this saying by Dame Jane Goodall: what you do makes a difference, and you have to decide what kind of difference you want to make. So what kind of difference are you going to make in the lives of your patients today? Quickly, I'm just going to go through incidental findings just to answer that quick question. Many of these research projects looking at incidental findings are really self-reported surveys, and so that makes it a little bit difficult for us. But we can go off of what we have seen and extrapolate to how this might affect you in your office. So the very, very first paper that came out was in 2007. Largely, we're talking about orthodontic patients. So we've got a young patient population. They found incidental findings at about 25% of the time. And largely, the largest one, of course, was Airway. Next, in 2012, Price did a survey, and these were mainly older patients, so implant patients. In the older population, they found about 3 incidental findings per scan. Again, Airway being the largest. Next, calcification, something in the bone, something with the temporomandibular joints, endo, developmental, and about 0.1% was pathological. What did they do with these? Well, they found that when they had this type of incidental finding, the majority you didn't need to do anything with. About 16% some type of referral or intervention, and another 16% active monitoring, meaning you re-imaged the patient in a certain amount of time and decided if there was a growth potential that would let you know that there was some type of pathology. 2014, Edwards did a survey as well. Again, this is young patients, orthodontic patients, mean age of 14. And with those patients, they found 2 incidental findings per scan. Maybe over time, we're better at looking at our scans. And so they found definitely a lot of airway issues, a lot of issues in the sinuses as well. So this tended to be the larger area for incidental findings. What do we do with those? Well, the studies have a very broad range. They say 10 to 50% are actionable. It's a pretty large range. Probably on average, about 30% are actionable. And those actions would include treatment, maybe other diagnostic tests, active monitoring, or referral. All right, what are the legal responsibilities as a owner? Who is responsible for reading the CBCT data? Well, the dentist who obtains the volume. The exact same thing as we always were for panoramics or lateral cephs. In fact, all of this anatomy we were seeing before, and we were responsible for before. We just couldn't see it very well. So much better in 3D. So what are our overall responsibilities? Well, the entire scan volume should be examined. We need to be able to recognize abnormal and refer appropriately. There is free training that is now offered by CEREC doctors. So when you purchase a machine, you get a free 2-day training. And there are oral and maxillofacial radiologists like myself that are here to help. In fact, many times we put on courses, so you can find a CBCT course on anatomy and pathology, so these are readily available. And we know the radiographic signs really don't change that much for cone beam CT imaging. They're very, very similar between 2D and 3D. We also have something very exciting to share. We have a dental radiology diagnostics button. This goes directly to my private practice. So if you are looking through something and you say, I don't know what that is, you can press that button and it would get sent directly to me, going right into our HIPAA compliant secure servers. And we would be able to look at that case and read that for you. We also have exciting educational website coming. This is all radiology CE courses. And so this should be starting in about November, December of this year. And you could go online and look at everything from the comfort of your home. Right. And that is when a radiologist takes a selfie. So thank you very much. If there's any questions, you can email it down here, webinars@henryschein.com.
And Dr. Heidi, we actually have a couple of questions right now that I've received. I'll just read a couple for you. The first one is 3D more technology than what most general dentists need or encounter on a daily basis?
I would say the 3D technology is exactly what a dentist needs and encounters on an everyday basis. We see so much more with 3D imaging than we ever saw with 2D imaging. And you'll see that as you start to go through and look at your 3D scans. We're seeing so many more periapical lesions in particular, but we see quite a bit going on even in the sinuses. And so it's great for our patients, especially if we're passionate about being able to help them, and especially if we're passionate about whole patient care. I mean, can you see that there's calcifications in the neck? Yeah, we can see those. We can see if the patient has a calcified carotid atheroma. It's not too much technology because it's exactly what we need to even be able to place implants. And I would say the way that we are moving in our society, at some point, these things will become standard of care, that we will need to have 3D imaging to be able to appropriately treatment plan our patients.
Great. Here's another. How would you decide who to use this tech on?
Well, that's an excellent question. There are some 3D guidelines that we can go to. What we're seeing with some people is that, they will take a panoramic or their full mouth series, and then if there's something they can't quite tell what it is, or if they're not able to diagnose the patient's pain or discomfort, then they move into 3D. Or if they're going to be planning an implant, then they'll move into 3D. But on the other side, we do see some offices that have changed their full mouth series. And now their full mouth series is really a cone beam CT and 4 bite wings, just because they're seeing so much more and they're able to more appropriately treatment plan that patient case.
All right, another question. What type of insurance coverage can be expected?
Oh, that's an excellent question as well. Of course, the insurance companies are not too keen to pay for this technology. And so that's made things a little bit difficult for us. While we know that the patients most likely need a cone beam CT, getting paid for it is another matter. Um, and I expect that this will definitely change, especially as our standards in our dental society start to change. At least I would hope that it would. A lot of people are looking into medical billing because medical billing will pay for the cone beam CT. Others will charge it as part of a, maybe an included fee. So the price of your implant includes X, Y, and Z, including the cone beam CT, because you know that you need it. Others will charge it out as maybe a pan or ceph if it's a large field of view and does get the condyles. But we're starting to see insurances just beginning to pay for these. But I think that a majority of the way that they're getting paid through insurance is through medical insurance. So medical billing is becoming very, very popular.
Are extraoral bite wing x-rays available with CBCT?
Well, most cone beam CTs that are on the market, they come as a pan and CBCT unit. So you can decide if you'd like to take the panoramic or not. And with that would have those extraoral bite wings. What we do need to remember, though, with the extraoral bite wings is that we are still using panoramic geometry, and it's a fairly low resolution image. And so in a lot of the research we've done, many of those lesions have to be extensively large to be able to pick them up on an extraoral panoramic bite wing. Definitely has a place, especially if you have a patient that is a gagger. It's better to have an image than not have an image. But we do need to remember the limitations for those extraoral panoramic bite wings as well. But just know, most machines you have the ability to either take the pan or take the cone beam CT.
Do you have to have a written report for each CBCT scan taken in a private dental office? The person says that they know there are dental radiologists that can provide such a report. Is one required when the volume is read by a general practitioner?
Oh, that is an excellent question. And of course, we do see different schools of thought with what is out there. What is our legal and ethical requirement? Legally and ethically, every scan should be looked at. Every scan should be evaluated in entirety for pathology, whether that is done by the general dentist or by a radiologist, either way. A report is not a legal requirement, although if you find something you don't know what it is, certainly at that point, it would be prudent to go ahead and refer that on. We know that, of course, we'll get held to the same standards as our specialists. So I think that the great rule of thumb is make sure you look through all of your scans. The people that get in trouble are gross violators that never looked at all, especially if it's in our area, in the maxilla or the mandible. And again, if you come across something you don't know what it is, at that point, you'd want to go ahead and refer it on. Very similar to, doing an extraction. If you see a third molar that is really close to the canal, you may not want to do that one in your office. Can you do third molar extractions? Of course you can. You're probably very good at it. But if it's one that looks like you need to refer it, it's probably prudent to do so. And it's the exact same thing if you're looking through your scan and you just see something that you're not quite sure what it is.
Another question. Is there a network of doctors that consult on your network?
We do have a network of doctors that consult. And I think that's one of the really fun things with radiology is that we're kind of a nice bridge between dentistry and medicine. And so we do have consultants on both sides of the fence. And so we can always, consult with each other. There's a group of us, or we can consult with our medical colleagues.
Great. Well, I think those are all the questions we have time for today. Thanks everyone for attending today's webinar. We really appreciate your time and your participation. If you had any other questions that we weren't able to answer or get to today, please email them to us at webinars@henryschein.com and we will follow up with you. If you missed anything or you wanted to go over something that you might have missed, not to worry. You will receive a link to view the recording of today's presentation in the coming week via email. And we definitely look forward to having you at our next upcoming webinar. It's going to be on November 5th, featuring Mark Rosen, CPA CSP, where he'll be discussing 2019 year-end tax planning, deductions, equipment purchases, and overall tax strategies and updates. So on behalf of Henry Schein, thank you so much, Dr. Kohltfarber, for an amazing webinar. And thanks again so much to all of you for attending. Have a great day.
Thank you so much.